All right. Good morning, everybody. This morning we are doing PUPD, which is such a good topic in preparation for the exams because there's so many questions I can ask on it. So does anybody not want to be asked questions? Nobody said. Nobody has opted out of questioning. Excellent. Emily's silent, so
Microphone's not working in the chat, but maybe you can ask her in the chat then.
Yeah. Yeah, she might have to type response. So essentially the way I'm gonna structure this is rather than try and cover everything that's in Edinger, I've just kind of picked out the stuff that I think is examinable. Just to try and kind of really target it and give everyone sort of practice of what sort of questions might pop up and stuff like that. And then the other topic was like essentially disorders of micturition, disorders of urination, which again is quite, I like. There's certain like kind of elements of it that I think there's really good evidence-based kind of knowledge around it, and I can ask you a question which helps me to understand your level of understanding on certain topics. So I'm really glad we're doing this topic this week as the last one before the writtens. So the first topic is PUPD. Can somebody please tell me define central diabetes insipidus?
I can give it a shot, but I'm not exactly sure because I'm not studying for membership. But my understanding is that it is when they're PUPD and they're often hyposthenuric, and you've kind of ruled out everything else.
What's the mechanism of it?
Oh, something's still
Okay. Yeah, so it has to do with the regulation of vasopressin or the antidiuretic hormone.
Good. Can I just highlight vasopressin and antidiuretic hormone are the same thing?
Yes, it's the same thing.
Yes, it was embarrassingly far through my study before I worked that out.
Wait,
Because different textbooks just use the one word, but they're interchangeable.
What are the two words? Sorry, I missed that bit.
Vasopressin and antidiuretic hormone.
Are the same
And
thing.
arginine as well is the same thing, isn't it?
Arginine, vasopressin, yeah. So
Emily written in the chat central versus nephrogenic. But
that.
Yeah.
Emily, yes. Central versus nephrogenic. So the question was define central diabetes insipidus.
But central is psychogenic most of the times, isn't it?
Is what?
It's psychogenic.
Oh, so central diabetes insipidus actually describes the absence or deficiency of ADH.
Right. Okay.
Yeah. So psychogenic polydipsia, like almost different category.
Okay.
Yeah. So as far as central diabetes insipidus, okay. What is ADH? What does it do?
So the antidiuretic hormone, it's released and acts in the tubules of the nephron and tells the body to reserve water by conserving sodium. So sodium has the osmotic gradient of pulling water in, and the body doesn't lose water through the urine. That's very scientific, but yes, something like that.
Good. That's very good. So we all know what diuretics do, right?
Yep.
What does furosemide do?
Gets rid of fluid from the body.
Yeah, so it increases urination. So if we've got antidiuretic hormone, it's almost like a double negative, but it means you're going to retain fluid. Natalia mentioned the tubules. Can anybody be a little bit more specific about that? Which tubule or where it works?
The distal tubules and collecting duct.
Good. Excellent, Aileen. Now, why is where it works important? Would ADH work if the receptors were in the bits of the tubule that sit out in the cortex rather than in the medulla?
I don't think it would, because in the medulla you've got your osmotic gradient, so your medulla is really hypertonic. So
Right.
it naturally causes the water to be drawn out from the collecting ducts via the osmotic gradient, whereas in your
Excellent.
cortex, it doesn't have that. So the water wouldn't naturally move out of the tubules.
Exactly. So we are relying, so what ADH does is just opens up, it actually inserts aquaporins, because aqua's pouring in, yeah? Aquaporins, which are water transporters into the collecting duct membranes, and the water can pour out, but it's a passive process. It's not active. It's not like water's being pumped out. So we're really reliant on that concentration gradient between the urine being less concentrated than the medulla. And we don't have that hypertonicity in the cortex. It's only in the medulla. So the bits of the tubule, so you probably remember glomerulus, proximal convoluted tubule, antler cortex, loop of Henle dips down into the medulla. Distal convoluted tubule in the cortex, collecting duct, collecting tubule, that then dumps into the calyces, renal pelvis, collecting system, and down into the bladder, right? So by the time the urine or the filtrate gets to the collecting duct, it's pretty concentrated, isn't it?
Mm.
So the medulla has to be more concentrated than that for ADH to work. So you can have all the ADH in the world, but if you don't have medullary hypertonicity, it's not going to do anything.
Right. So that's why it'd be nephrogenic, right? Like that's where
Define nephrogenic diabetes insipidus.
what you just said.
Yes.
When you've got all the ADH in the world, but if it's not hypertonic medulla, then it's not going to actually work.
So interestingly, that loss of medullary tonicity is one of the mechanisms of nephrogenic diabetes insipidus. What might be another reason why ADH doesn't work at the kidneys?
Insensitivity to ADH due to hyper-A.
Yes. What else?
I don't know how that happens.
It's the receptors. So the ADH receptors are there waiting for ADH to get attached, and then the aquaporins go into the cell membrane. So if something's blocking that receptor, the ADH never attaches, and we never get triggering of aquaporins, or the ADH has a reduced effect.
And you see that
universal for receptor. Don't actually know what it is. This is how I envisage them looking, but they may not be accurate.
That's how they drew them at uni. I remember.
I agree. This is all receptors, right? Could be in the immunoglobulin too. Either way.
So you see that both in Cushing, you see that in Cushing's, but would you also see it with iatrogenic steroids? Like, is that why they're PUPD when you give steroids?
The mechanism of PUPD with exogenous and endogenous cortisol is multifactorial, but that's one of the factors. Yeah.
Oh, interesting.
Interesting. What else impacts ADH receptors at the level of the kidneys?
E. coli. I don't know the mechanism, but
who said that?
Me?
I said it.
Yay! What is the mechanism for PUPD with pyometra?
E. coli endotoxins.
Good. Binds to the ADH receptors, stops the ADH from working. So good. Okay, what about can somebody define for me primary nephrogenic diabetes insipidus versus secondary? We've been talking about secondary diabetes insipidus. What's primary nephrogenic?
The receptors themselves are faulty.
Yeah. Good. Yeah. So it's usually genetic. They're usually really young animals. So essentially they don't have the ADH receptor, or the ADH receptor doesn't do it's like then intracellular signaling. It's malfunctioning. So there's a few families of dogs that have had that reported. They're very dehydrated. So that's the difference between primary is the actual receptors dysfunctional, and secondary is something else in the body is causing receptor dysfunction. Cool. What would the mechanism of receptor dysfunction be with Addison's disease? Or what's the mechanism of PUPD in Addison's disease?
So maybe it's a lot of the concentration gradient, is it?
Good. Yeah.
And also the something to do with aldosterone.
Mm.
The
we-
mineral deficiency.
Say again.
It has something to do with the mineralocorticoid deficiency.
Ooh. What does aldosterone do?
Reabsorbs sodium,
Yes.
contributing to the concentration gradient.
Yes.
So is that medullary solid washout? Does that count as that?
I think, sorry, I'm gonna have to turn you up again, Maya. Sorry. Say again.
Does that count as medullary solute washout?
Sure. It's one of the mechanisms, yeah. So what happens when so aldosterone facilitates sodium resorption. What follows sodium?
Water.
Water, exactly. So if you block sodium resorption, you also block water absorption. So that's one of the mechanisms where the water and sodium just stay in the tubule, they never come out. It's at a different, it's not at the ADH receptor level, it's a different mechanism. But then these dogs have hyponatremia. What do we rely on for our osmotic gradient or concentration gradient?
Sodium and urea.
Good, yeah. And sodium. So if we're hyponatremic, we don't have we're hypoosmolar. So we lose some of that concentration gradient.
So EUPD is secondary to the hyponatremia that we see on the blood work.
And also that you can't, like the hypoaldosteronemia, so you actually can't retain sodium and water. So the water just goes straight through. But then typically, if you had a functioning medulla and functioning ADH receptors, then the aldosterone would let the water through and then the ADH would reabsorb the water later on down the tubule. But because you've got the loss of the medullary tonicity, you also lose that ADH kind of fail-safe mechanism.
Yeah, okay, so you see both.
Yes, exactly. Yeah. Can somebody please differentiate a primary polyuria from a primary polydipsia and give me an example? So first question, define primary polyuria and give me an example of disease that causes that.
Haematuria. You say primary polyuria?
Primary polyuria. So what is primary polyuria? Like if we've got a patient with PUPD, why do I want to differentiate? Sorry, not primary nephrogenic diabetes insipidus, but primary polyuria versus primary polydipsia. Why do I want to differentiate?
Losing the water and then you've got to catch up by drinking.
Exactly. So these patients are always PU and PD. We want to differentiate whether it's a primary polyuria or a primary polydipsia. Yeah. Most of the time it's a primary polyuria. So a good example of primary polyuria is any of the things we've just spoken about. What's an example of a primary polydipsia?
It's more behavioral, isn't it? When they drink a lot more, often due to stress, and then they urinate more to compensate because they've drunk so much.
Yeah, so it's pretty rare. Primary polydipsia is pretty rare. Cushing's actually interestingly impacts central like osmolality detection. Don't quote me on this actually, but there's a combination of primary polydipsia as well as primary polyuria in Cushing's, which is interesting. And they think hepatic encephalopathy is associated with central primary polydipsia due to its impact on brain function. But there's actually not very many primary polydipsias. Most of them are primary polyurias when we have PUPD patients. But if you've ruled out all your primary polyuria causes, do an MRI on your brain after liver function testing. What other way might liver failure cause a primary polyuria?
No urea is being produced, so
Good.
concentration gradients affected again.
Excellent. Very, very, very good. Yeah. And also they're quite hypoalbuminemic as well. So everything gets a little bit leaky. We lose the concentration gradient in the medulla, but we also use the osmotic protein side of things. So we rely on the oncotic pressure in the vessels to attract the water out of the medulla and into the blood vessels to take the fluid away to maintain that tonicity. Is that too much? Sorry. Too much. We don't need to cover that. This is not membership level. Okay. So what if we had, okay, questions. How would glucosuria alter the volume of urine being produced?
Increase it?
Osmotic gradient. Yeah.
Yes, good. So the difference between the tubular filtrate osmolality and the medulla osmolality is not different enough. The water won't flow out. What about hypercalcemia? What will that do to the volume of urine production?
Increase.
Good. How?
Don't know why. How? Yeah.
The hard one. Hypercalcemia is one of the things that actually obstructs the ADH receptor or decreases function of the ADH receptor. So we see polyuria associated with hypercalcemia.
Is it because maybe I know, but I'm not too sure. Because the calcium dilates the afferent arteriole that goes to the glomerulus, and perhaps the glomerulus gets more
Blood flow.
Yeah.
I don't know, actually. I know it directly impacts the ADH receptor, so we get loss of water resorption, but there might be alterations in blood flow as well, because calcium's a cofactor in pretty much every reaction in the body. So there's more subtle effects that we don't measure, for sure. Okay, what else do I want to ask you about? Tell me, define Fanconi syndrome.
Tubular glucosuria.
Good, yeah. Is it just glucose that they lose?
Protein as well.
Yeah, a little bit of protein or amino acids, they say. Yeah. Anything else? Two more things.
You lose bicarb and I can't remember. Potassium or sodium, but I can't remember which one. Or is it?
I'm totally blanking as well.
Sorry, what was the question? I lost you guys there.
Oh, no worries. It is, what is Fanconi syndrome? What do they lose with Fanconi syndrome? And I remember there's 4 things, but I can't remember the 4th.
3 would be fine.
Right. So we've definitely got bicarb loss. We've definitely got amino acids or small protein loss, because it's only the little proteins that made it through the glomerulus that don't get absorbed in the proximal tubule. So what are we gonna get polyuria associated with Fanconi syndrome?
Do you not?
So there's increased glucose, increased bicarb, and increased protein in the urinary filtrate. How's that going to impact resorption of fluid?
It causes an osmotic gradient, but the rest of the kidney can still reabsorb. So does that sort of counteract that, or?
Yeah, so it probably won't be a really profound polyuria, but the very last chance we have to reabsorb fluid is the ADH, and we rely on that medullary tonicity for that. And the difference between the osmolality in the filtrate and the medulla for that resorption. So if you've got a hyperosmolar filtrate because you've got glucose and amino acids in there, it's going to keep the fluid in there, isn't it? Does that make sense? I'm nodding, yes. I've got some lost faces. Am I
I
going
actually need to review all of these physiology because, yeah, holy moly.
Holy moly. Sorry, I get really excited about this.
Oh, yeah.
I've reviewed it about 100 times, and every time I review it, I'm like, I've never read this before.
Are you sitting this year, Natalia?
Sorry?
Are you sitting the exam this year?
No, not this year. I'm hoping next year, but like, yeah, I don't know. And one day I'm studying, like, but yeah.
Fair enough. I mean, you sat massive exams recently.
Yeah. So tell me, I have gone into too much detail, and like that going into this session, I was like, this has to be a confidence building session. So I do apologize for going too deep on renal physiology. You won't get asked about renal physiology like in that much detail, but I love, like, if you really understand that the very last step in water reabsorption, or our last opportunity to reabsorb water, is in that collecting tubule as it dumps into the renal pelvis, essentially. And we're totally reliant on that hypertonic medulla and the ADH receptors facilitating that. So if you understand the kind of balance between the filtrate osmolality and the medullary osmolality and the water movement there, it will just, like, you can then predict what would happen in the kidney with different diseases. It's like one of those sort of principles that you're like, oh, it makes sense. So we'll move on from renal physiology in 1 minute. Somebody define the mechanism of action of desmopressin to me. Nope.
Is it just synthetic ADH that works, I'm guessing, the same way as ADH does on the vasopressin, like the ADH receptors in the kidney?
Yes, that's exactly right. So it's just ADH. You're just adding ADH to the picture. So I love this as an exam question. So if you know what ADH does, if you've got a patient with central diabetes insipidus, what will happen to the urine USG with supplementation of ADH, of desmopressin?
It'll increase.
Increase. Excellent. So if I were an examiner, I would think this is probably fair game. I would say desmopressin acts at the ADH receptors as a synthetic vasopressin or ADH analog. What will happen to the USG with central diabetes insipidus? What will happen with partial nephrogenic diabetes insipidus?
Should increase.
Should increase a little bit, yeah. So it's that if you've got a certain amount of ADH being produced from the brain and it's just not enough to, like, cover the ADH receptors at the kidney, then adding more will result in more effect and you should get an increase in USG. What about primary diabetes insipidus, nephrogenic diabetes insipidus? What will happen if you give ADH?
It won't change.
It won't change because those receptors don't work. So the difference between complete and partial nephrogenic diabetes insipidus is one of the ways that you can sort of use ADH, like a desmopressin trial, to diagnose PUPD.
Is that the same drug that causes von Willebrand factor release? So that's what I've only heard it in that context.
Yes. So we use desmopressin. So, you know, like one of the tests for diagnosing PUPD, once you've kind of done the usual tests, is a water deprivation trial. What are the risks of water deprivation tests?
Dehydration.
Yeah. Yeah. And these patients have just got no ability to regulate. Like if you're withholding water and they're losing water and you actually don't know how rapidly they're losing water, and it's like, unless you've got a urinary catheter in and you can sort of say, okay, that's liters and liters, and you're sitting watching the bag, and monitoring their electrolytes and monitoring their weight. And like, it's a very intensive process to do that safely. So what I've kind of moved to doing, and what a lot of the literature sort of says, is doing a desmopressin trial instead. So you do a week of desmopressin and see what the USG is at the end of the week. And it just helps you understand, okay, well, now I've got a concentrated urine. It's either going to be central or partial nephrogenic diabetes insipidus. And then you cut your differentials in half, right? So then I can sort of sit and watch if it's still not concentrated, and then I can withhold water and sort of say, okay, well, I know that I've concentrated, like the medulla's nice and concentrated and stuff because I've used it as desmopressin. Now I can do my kind of modified water deprivation test with only half my differentials remaining. What effect will a high salt diet have on urine volume production?
Increase?
Yeah, exactly. Yeah. So it's one of the differentials I just want everyone to have on their list because it's so common. I must have said this a million times in these tutorials, but people will be giving like, we had one the other day and we did an ultrasound. It had a stim test, it had bloods, it had all the investigation. And I just said, what are they feeding it? And they're getting these meatballs from the supermarket, and they're like 40 times the salt that like Hills would have in it. It's just
well, that was a very expensive workup to find out that they're keeping it on their diet.
Yeah, they literally changed diet, and then the PUPD developed. Yeah. So it's just something like, what diet is the dog on? Like first question in the history in a PUPD presentation, or what treats is the other thing, because they might give a really good diet, but then they give like a salted bone or something like that once a day. Yeah. So how would salt cause an increase in urine production?
Because of the sodium osmolarity gradient, it attracts sodium in there, and then the patient urinates, and then they will get a compensatory polydipsia, right? Otherwise, they will become dehydrated.
Yeah, exactly. So actually, there's two mechanisms of polydipsia in these patients. So you're going to get an instant blood hyperosmolality from the high salt. So they're going to drink more from like central stimulation, and then they're going to urinate more as well. So high solutes, glucose, sodium, and mannitol is an iatrogenic one, are going to increase urine production. That's one of the mechanisms.
Mushrooms.
Sorry?
There's lots of mannitol in mushrooms.
Is there?
Yeah.
Like mushrooms that we eat?
Yeah, the good ones.
Not the bush ones.
It's a FODMAP. If you have to do a low FODMAP diet, mannitol is one of the mushrooms you can't have while you're doing your mannitol trial.
Wow. That's so interesting. I love bouncing. My mother-in-law's a dietitian, and I love just bouncing, like you have these conversations with her. She helped me study for my fellowship, and she was like, oh, what about this? And you just get these perspectives that we've never comprehended in the veterinary industry. But yeah, exactly like that, mannitols and FODMAPs and post-infectious food sensitivities and blah blah blah. Yeah, it's really interesting. Okay, what else do I want to ask you? I think I've had enough of PUPD. Does anybody else want to cover anything?
I'd love to ask a question.
Yeah.
So if you have, let's say you have, I don't know, 13-year-old cats with recurrent episodes of a UTI, and then let's say the GP vet has been managing the UTI, and then you're like, okay, well, actually, why is this cat getting these recurrent episodes? Let's take bloods. You take bloods, and then you notice that the cat has hyperthyroidism, and then you're like, okay, well, that causes PUPD, then the urine is diluted, that's why the cat is getting ongoing UTIs. And then I was reading in Attendees, and then they said that very rarely a cat with hyperthyroidism develops UTIs. So yeah, I don't know. Am I wrong with that way of thought? I was like, yeah, PUPD, dilute urine, recurrence of UTI, that's why it's happening. If I manage the hyperthyroidism, the likelihood of this cat, I guess, developing ongoing UTIs is less, but I don't know. Is that the right process?
I would completely agree with you there. So this is a great exam question. Describe the innate barriers to development of urinary tract infection in the bladder. Concentrated urine is one of them. So Natalia sort of alluded to the fact that the reason the hypothyroid cat is getting recurrent UTIs is because they've got dilute urine. So if you've got really concentrated urine, it's a very hostile environment for bacteria to grow in. What other factors do we get compromise of immunity in the innate immune system?
Could you describe the sphincters as mechanisms?
Yep. So continual flushing. So if there's like flush backwards, like if there's not tone in those sphincters, then absolutely, for sure.
Intact mucosa.
Intact mucosa, good. So that's just the barrier, right? So if you've got a mucosa that's inflamed and oozing, so for example, if your hypothyroid cat also actually has idiopathic cystitis, then it's adding nutrients for bacteria to grow into the urine, isn't it?
Yep.
And providing more binding sites for bacteria to bind on if that barrier is disrupted. Excellent.
Uroliths.
Yes, good. Excellent. What about a dog with Cushing's? Got dilute urine. What about
Immunosuppression?
the cells of the innate immune system function?
Suppressed, so they won't mount a response even if there are bacteria.
Yeah, exactly. So if you're sort of asked that question, I want you to think about what are the kind of physical barriers to infection, but then also that innate immune system is still included in that kind of primary response. So we have to have a functional innate immune system to ward off UTIs. Excellent. So yeah, I'm not sure why Adam just said that hypothyroid cats rarely get UTIs, but I guess they've got more flushing because they're PUPD. They might be dilute, but they've also got more flushing, so maybe it kind of balances each other out. So can someone tell me, when you've got inflammation in the bladder, how does that impact urination? What do we see clinically when there's cystitis?
Pollakiuria.
Pollakiuria, yeah. So what is pollakiuria? Define that for me.
Frequent, smaller urination.
Yeah, increased frequency, smaller volumes. So let's think about that kind of biomechanically. What's actually happening in the bladder to cause increased frequency and decreased volume?
Irritation stimulates urination. I don't know exactly how, because it's usually stretch that stimulates it via the pelvic nerve. Is that right? But I don't know what would cause what the mechanism would be for irritation. I just know that it makes them feel like they need to go when they don't, similar to colitis as well. It does the same thing.
Exactly, yeah. So inflammation often increases muscle tone, except in esophaguses and bile ducts. There it decreases muscle tone for whatever reason. But in the bladder, when we've got inflammation, or in the colon, as you say, when we've got inflammation, we get increased like spasmodicity. What's the word? Reactivity of the detrusor muscle. So for a given degree of stretch, there's more nervous stimulation from the pelvic nerve, as you say. So I'm going to quiz you on neurologic control of urination in a sec. So I won't give too much away. So we get increased stretch of the muscle, which is, same amount of stretch, but more reactivity. So the detrusor muscle, the muscle itself, goes like that when it gets stretched, where previously it only contracted when it got stretched this much. to increase reactivity of the muscle when we've got inflammation. So that's what kind of produces the clinical signs. Can somebody tell me about the neurologic control of urination? Aileen, sorry.
So there's the hypogastric nerve, which comes from L1 to L4, which goes down to the bladder, and it has two arms, like the beta and alpha, that go to beta and alpha receptors. And so the beta receptors allow the bladder to fill. And then the alpha arm controls the internal urethral sphincter and causes that to contract, to stop voiding. So the hypogastric nerve is the one that is like this sympathetic arm and allows the bladder to fill. Then you've got your pelvic nerve that then is stimulated, and that controls the detrusor muscle contraction.
Good.
And so when it's stretched, it sends a message to the brain to that it's big enough to want to urinate, and then it goes back down the pelvic nerve, causes contraction of your detrusor muscles and relaxation of the internal and the external sphincters. And the external sphincters controlled by the pudendal nerve under somatic control.
You nailed that. That was amazing. Yeah. So the one thing that, like, you would get full marks on that, the answer to that question, the one thing that I would add in there is, just because it helps me mechanistically, you mentioned the kind of with the like sympathetic phase of like urine retention, but you didn't mention whether like it's parasympathetic in that pelvic nerve, the detrusor, like actual detrusor contraction and conscious urination. So parasympathetic pelvic, detrusor contraction, and urethral dilation. But yeah, you got the nerves right and you got the receptors right and everything. So given that Aileen has just schooled us on where the receptors are and stuff, tell me mechanism of action of prazosin. Is that how everyone says that?
I say prazosin, but you know.
I'm pretty fancy.
The thing is you just read it most of the time. Like, you rarely talk about it. You just read it on the box or on Fin when you look up the dose.
Yeah. I'm sure. Yeah, I'm just conscious that like I say prazosin. Why did I say a long A? I don't know where that came from. Tell me, how does it work?
Is it an alpha antagonist? So it causes relaxation of the internal urethral sphincter?
Yes. Do we use it with idiopathic cystitis?
Not anymore.
Oh, who is up to date on their critical care knowledge? That was well done. We need buzzers. Yeah, so traditionally we use prazosin all the time, right? Just relax the urethral sphincter in cats that have got urethral spasm. But there's been like pretty good quality studies now that have showed that it doesn't improve outcomes and it doesn't improve anything, and it might actually predispose to recurrence when you wean them off. So the recommendations now from the criticalists are that we don't use prazosin with idiopathic cystitis.
When would we use prazosin? Like, when's it indicated?
When they've got a phagochromocytoma.
That's
the only thing I use it for now. What else? Okay, what other urinary condition might we use prazosin for?
Would you use it for potentially medical management of like ureteral lifts as a potential option if they can't place a sub or something like that? But is it tamsulosin is much more proven to be more effective than prazosin at that?
Very good. Very good. Yes, so tamsulosin is another alpha-2 antagonist. Maybe it's an alpha one. It's an alpha. But it's supposed to be more effective. It's what they use in humans with ureteral stones, and also humans with prostatic induced urethral spasm as
Sorry,
well.
what was the name?
Tamsulosin.
And so how does it help with ureteroliths? I don't like it.
So I can't remember the exact location of the receptors, but the ureters have slightly different alpha receptors than the urethra. And theoretically, tamsulosin should be better at relaxing the ureter when there's ureteral spasm. So if you've got like a 2 millimeter stone in the ureter, theoretically it might pass, but the ureter is like holding onto it like this and causing the obstruction. So if you can relieve that spasm, then you're going to improve your chances of it passing. In theory, we've got no evidence to say that that works, but we do it. But we've got no evidence because the study hasn't been done with enough numbers to actually be conclusive. Not because we know it doesn't work, if that makes sense. Yeah.
Anecdotal rather than proven.
Yeah. So it's kind of like apparently like there's no study that says furosemide works for congestive heart failure, but it would be unethical to do the study where you had a like.
Oh yeah, fair enough. You put all these dogs with heart failure.
Yeah, exactly. Like we know it works, right? Yeah. So it's very low risk. The only risk is really hypotension, and most of these guys are hypertensive anyway. So go for it.
Can I ask something?
Like if the cat's been recently blocked, like with a urethral blockage, you were saying that the study has revealed that it doesn't actually help, but it impacts the potential for them to recur. Why would it cause recurrence, prazosin?
I think so if you use like a beta blocker, so similar like adrenergic receptor, we know that the number of receptors actually increases, like almost doubles.
Right.
So the body really wants that mechanism intact. So it will use means to increase the efficacy of what little adrenaline there is.
Yeah. Okay.
So we don't have the studies to say that that happens the same way in the urethra or ureter and alpha receptors. But in theory, what could be happening is that the receptors are all there waiting, and then you withdraw prazosin and you've got double the reactivity as you'd get normally for the same amount of catecholamine.
Yeah. Okay.
Does that make sense?
And it doesn't really help to begin with, so it's not worth the risk of giving. Yeah.
Yes, exactly. Yeah.
Sorry, thank you.
So, yeah, and Natalia, you had a question as well.
Yeah, so do you guys, so I think Jack did mention feline idiopathic cystitis. Do you guys use cartrophin, so pentasample sulfate, and also instead of processing, have you guys used botanical in cats?
Botanical.
Botanical.
Oh, botanical. I was like, God, is this some homeopathic thing? Sorry. I don't know about that.
It's just my lovely Spanish pronunciation.
It's like me pronouncing medicine names. I don't know. I just read it. Okay, tell me the mechanism of action of botanical.
I don't know.
No.
It doesn't it cause the detrusor to contract?
Yeah.
So you only want to use it for detrusor atony if you've got a patent urethra.
Good. Yeah. So it is indicated in some of these patients. So these patients that have had overfilling of the bladder and bladder stretch, and then have a really large flaccid bladder but no obstruction to expression of that bladder, they're good candidates for bothanicol. But if you've got increased urethral tone and a like hard, firm, small bladder, that wouldn't be a patient. I wouldn't want to put that patient on bothanicol. I used to work with someone that used to do prazosin or phenoxybenzamine, similar mechanism of action, and then half an hour later bothanicol. So they'd like relax the urethral sphincter. Bron knows who this is. Bron and I together used to work with someone that used to do that. And Aileen probably actually. Yeah, still? Yeah. So it makes really good theoretical sense, right? So that's the urethra contracts the bladder half an hour later. But we just don't have evidence to say that it works really well. Yeah, I wouldn't want to do it if they had like an obstructed urethra or a spasmodic urethra.
And for pentasample sulfate?
Oh, yeah. There is soft evidence and very much theoretical benefit to glycosaminoglycans in cats with FIC. but no real positive outcome studies. And again, it may be the quality and size of the studies. It's not going to hurt.
Okay.
That's my impression. Yeah.
Do you do it the same as you would with like arthritis, where it's once a week for 4 weeks?
I don't know. Actually,
I'll look that up.
yeah. Because it's such an acute presentation. Like maybe you just use one shot, but then maybe it's prevention long term. I don't know.
I will look it up.
Thank you.
Maybe
Please
next
let us
session.
know.
Let's look it up, Alex.
Next rounds we'll do. Alex, what did you learn?
Yeah, we can do a video.
We'll do a video. Yeah. Check our social media. Okay, tell me the mechanism of action of phenylpropanolamine. Propylene.
Alpha 2 agonist?
Good.
Alpha
Opposite.
1 agonist.
Yeah. Opposite of prazosin. What conditions do we use it for?
USMI.
Good. Yeah. What about what important features of the physical exam would you note in a patient that has presented with a disorder of micturition?
I would want to look at the vulva if it was female.
Right? What are you looking for?
Really tiny vulva or any anatomical like mechanisms where there might be pooling or infection, dermatitis.
Right. Good, very good. Excellent. What else?
So I was watching them urinate.
Oh, I love that. Yes. What are you going to do before and after you watch them urinate?
Palpate the bladder.
Yes. What am I looking for?
Incomplete emptying.
Yes, I am. Exactly. Yeah.
In a female, a male's always incompletely empty.
Okay. Yeah. Excellent. And when I palpate the bladder, what am I noting? Size?
Tone.
Tone, exactly.
Any pain if they're not? If
Yeah.
they're like,
Excellent. Yeah. And if I'm putting a bit of pressure on the bladder and they do a little wee accidentally, then maybe that suggests that they've got a little bit of reactivity in there as well. Excellent. What else are we going to check?
The prep use if it's a male.
Right. Yeah. What about neurologic causes of disorder of micturition?
Yeah, like check the pudendal nerve.
Good. Yeah.
Bone and vulval winking.
Yeah. Good. What about gait?
they're not ataxic.
Yeah. Upper motor neuron gait. What about the part of the physical exam that everybody should do and nobody does, apart from an ophthalmic exam?
Rectal.
Cool.
Rectal, thank you. Excellent. What are we feeling for on our rectal?
Prostate, if they're a boy.
Good. Yeah. One more thing.
Urethra.
Yes. Nobody does this.
Oh.
You can feel the urethra really nicely as it goes over the pelvic rim. And there's very few ways that we can actually visualize that area. Like even doing like radiographs, there's bones everywhere. It's really hard to see a tiny stone in there. And you can literally like slide your finger along the urethra and go, there's a stone here. It's really real. Or there's a TCC here. Really rewarding when you find something. And
you would only feel the urethra if it's abnormal.
I reckon in some patients you can feel it when it's normal.
I reckon I've felt it. Never thought it. Yeah.
Yeah. If you go, because you kind of got to go side to side and it rolls under your finger. So you can feel it normally if you're
Like
looking
over
for
the pelvis.
Yes.
Okay.
And if there's alterations in thickness, firmness, if there's reactivity in certain spots, it's stone, like when you feel a stone in that spot, because it's one of the spots the stones get caught as it goes over the pelvic rim. It's like the dog will jump through the roof, but it's so rewarding to be able to know this is what I'm looking for, like contrast urethrogram rather than an ultrasound, which isn't going to help the whole thing. So really good part of your physical exam to make sure that you're noting, and as I think it was Bron said, anal tone is very important when you're doing your rectal, because there could easily be a neurogenic cause of micturition abnormalities.
I remember when I was a rotating intern, Anna, you said to me, the only excuse to not do a rectal exam is no finger or no anus. And I recall that to myself, I reckon, on a weekly basis. I'll like see an animal in consult and I'll be like, I got to do a rectal exam because Anna said I have no excuse.
Definitely have 10 fingers.
Yeah, exactly. I got 10 fingers. The dog's got a bum.
Yeah. One time, I think this story comes up, like any North Shore people will know this story already, but there was a nurse who saw a 3-year-old patient and was asked to do a rectal one, and they were like, no, it doesn't have an anus. That's genuine. I probably had one at some point.
Being 3 years old, yeah.
Yeah, exactly. It was like, is the wrong person to say that to as well. The person did not make him feel smart. Okay, tell me. One last thing. Can anybody describe the procedure? Do you think this is a reasonable membership question? First answer I want, and then I want the actual answer. Can you describe to me the procedure for a double contrast cystourethrogram?
That is definitely a reasonable membership exams for radiology.
Yeah.
100%.
Yeah. Probably not for
I don't know for medicine.
For medicine.
I agree. I think more radiology than med. Like you so rarely see it done. Like I don't think you do it much in GP, and even in referral, like I didn't really see it. Well, once maybe.
Yeah. Oh, it's so fun. So rewarding. Okay, what about if this patient is a 20-kilo female dog and with recurrent cystitis, and on urinalysis there's actually no evidence of infection, but there is 4 4-millimeter stones in the bladder on ultrasound. What are our options for management of the uroliths in this patient?
Urohydropotion.
Great.
That would be ideal, I guess. Because she's a big dog.
She's female.
Is it laser lithotripsy?
I think Sash might have access to it, but yeah, not commonly. Yeah.
Basket retrieval?
Sorry?
What about basket retrieval?
Yes, perfect. So cystoscopic retrieval. So those stones are small enough that they'll come out the urethra.
And you can try and identify what they are if you can with urinalysis and radiography. Try and dissolve them, I guess.
Yeah, so a key thing in this history is that there's no evidence of infection. So pretty much the only soluble stones are struvite. And there's always an infection there. Yeah. So yeah, what would we be looking for on our UA other than infection to say, oh, we've got a good chance of medical dissolution here?
The pH.
pH. What will it be if it's struvite?
High, alkaline.
Good. Excellent. Very good. And it's a good point actually, because sometimes these dogs have come to you when they've already been treated with a course of antibiotics. There might not actually be that much bacteria in the urine. They might culture negative, but that stone's still harboring the bacteria that was there before, and it's going to reinfect itself at some point. So you may actually not have an active infection, but it's important to not rule out medically dissolvable, manageable stones.
Do you find that the diets, because they sort of say that obviously they dissolve struvites but then prevent other stones, do you find that they're actually effective at preventing the other stones, or not really?
Yeah, but there's a reduction in incidence of the other stones. Stone formers are very determined. They like to form stones, but definitely there's a reduction in how fast those stones develop. because we've had patients that we've done cystotomies on like every 6 months, and we're sort of like, there's so many adhesions in here, we can't do them anymore. And we've definitely delayed the reformation of stones, like schnauzers and bichons are like really classic breeds for calcium oxalate, and they get stones after stones after stones. And we're really looking for really minimally invasive options rather than going to cystotomy in these patients.
So are you talking about you've had success delaying it with diet alone, or also with, say, potassium citrate and massive increase of water into their diet, like lots of intervention success, or the commercial diet alone?
Commercial diet alone, I feel like it does a lot towards prevention, but specific stones, then yes, I would. And those really like rapid recurrent stone formers, you need extras, and nothing works really.
Yeah, because I've found just some oxalate just so unsatisfying and so sad how much work that I just put in and it still comes back.
I know, yeah. And this is like, I feel like screening and catching them when they're small and doing urohydropulsion or like minimally invasive procedures is the key in these patients, because if they're already a centimetre when you diagnose them, it's surgery. But if you get them when they're
like
small,
just like that starburst formation of calcium oxalate makes me really nervous about urohydropulsion as well.
Yeah. Oh man, I had this dog that had hematuria, male dog, had hematuria for months and months and months, and there was no stones in the bladder. And we did a contrast urethrogram in him, and he had a stone just at his penile urethra. And we tried to flush it back and it wouldn't go back. We were able to pass a catheter past it, filled up his bladder and like squirted it out. And it was like a razor blade, like a cluster of razor blades in the urethra. And literally this dog presented with hematuria. Like it was just cutting the urethra on its way down.
Wow. So you can still do it. Obviously that dog, it's better to try to do it than to do surgery.
Exactly. So there's cases that I'd select it, but like if we can get them, you know, that 20-kilo dog with a 4 millimeter stone, they're going to come out really easily. So if we can get them when they're small enough that it's minimally traumatic, then that's optimal. All right, we better wrap up, guys. Good luck, anyone sitting exams next week. You won't need that. You've done the work.
Thank you.
Guys.
Have fun, and congratulations for studying this hard. You are much better, more knowledgeable vets than you were before you started. And we're doing a practice exam next session in 2 weeks. So we'll see you then.
Bye.
Thanks, Anna.
You don't have to do the written. All right, see you guys.
Bye.
Thank you.
Sure. Bye.